Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today. I'm your host, Sharlee Dixon, and today I'm joined by Tara Sundem. Tara Sundem is the co-founder of Hushabye Nursery and a passionate advocate for neonatal wellness. With over 27 years of experience in neonatal nursing, 18 of which as a neonatal nurse practitioner, Tara has dedicated her career to improving care for substance-exposed infants and their families. Specializing in neonatal abstinence syndrome, she developed the HOPPE program at Hushabye Nursery, which provides essential support for pregnant women with opioid use disorder. Recognized as a healthcare hero in 2021, Tara's compassionate, trauma-informed approach is revolutionizing the way we care for both newborns and parents. We're excited to have Tara on the show today to explore the growing crisis of substance-exposed infants, the barriers families face in traditional healthcare systems, and how Hushabye Nursery's innovative family-centered model is reducing reliance on medication, offering behavioral health support, and fostering lasting healing for both babies and parents. Tara, thank you so much for joining us. Welcome to the show.
Thank you so much. I appreciate
Absolutely.
the opportunity.
And so as we get started today, Tara, can you tell us what inspired you to specialize in neonatal care and then ultimately establish Hushabye Nursery?
Yeah, my mom and my aunt were both nurses, and I thought I wanted to do pediatrics. Ended up going into neonatal intensive care unit, taking care of babies, because at the time I got out of school, that was the only thing that was close to pediatrics that was available.
Sure.
Worked in the NICUs for about 25 years and started seeing more and more babies come into our neonatal intensive care unit withdrawing. One mom explained to me withdrawal is the worst flu and migraine times 100. And when she dumbed that down for me, I was like, that is exactly what we see in babies, tummy aches, can't sleep, fevers, sweats, shakes, everything that we have in the flu. And when she dumbed that down, I was like, my gosh, we put them in an environment that was created for babies that are born premature, that are, a pound at most. That's the environment we put them in. Bright lights, BP monitors. When you and I have the flu, we don't go to a rock concert. We, go in our rooms and quiet, dark environment. And when we started seeing more and more babies come into the neonatal intensive care unit, my eyes just I was like, what in the world is going on? And ended up in 2015, 2016, starting to call all of the NICUs around Phoenix and going, how many babies do you have they're withdrawing? And everybody's like, I don't know. And I'm like, no, I understand they're not our priority, which they definitely still are not our priority in the neonatal intensive care unit. But they started counting, and at any given time for the next 9 months, we had almost 24 babies withdrawing just in our East Valley is what we call it in Phoenix. That's a lot of babies. And no one really understood or even realized how many babies there were withdrawing. And most of those were going through that withdrawal process without the parents. And so imagine, I don't know if you have kids, but my kids were sick. They wanted their mom. And we would keep them at the time. Babies were with us for at least a month. I would tell families, you're going to be here for a month, but figure 2. And so can you imagine going through the flu for 2 months without your mom and dad? And it wasn't that the mom and dad didn't want to be there. It was the fact that in the neonatal intensive care unit, we don't know how to take care of substance use. We don't know how to take care of behavioral health. They make us nervous. My eyes were just really, really opened, and found that, when the nursery wasn't busy, when you had certain nurses at certain times of the day, babies did really, really well. And that just made us go, you know what, we got to do something. We got to make a difference. Heard about Lily's Place in West Virginia, where they were on the Today Show, and they'd taken babies from their neonatal intensive care unit because they had no room in the inn. And they put them in quiet, dark environment, and their length of stay went down. I mean, they weren't in the hospital for as long. They ended up doing better. The one thing at that time, though, with Lily's Place is definitely not trauma informed. They are now, but they weren't. It was one of those that the moms had to come in, watch a video, an hour-long video, and every time that they came in to
Oh,
see their babies. And a lot of times, our moms right now can't even make it an hour without using because they're so unwell. And so if you're telling them they have to do that and then they have to see their baby, it's not a good setup. And they've
right.
changed, they've revamped what they do, but that's how we started. And we initially were like, gosh, let's save the babies. That's what we're gonna do. The state of Arizona asked me, well, what are you gonna do about the moms? And I was like, oh, well, moms are not my important,
Yeah,
thing.
that's what I'm
And I
here for.
learned about adverse childhood
Hmm.
experiences. And as soon as I learned about that, our mission changed. It was not save the babies, it was save the families. And you would think that nurses and doctors learn about adverse childhood experiences. We don't.
No.
That is not something that is out there. It should be. Once I learned that and looked at the research and looked at the data, I was like, oh my gosh, we really do have to save the parents for these
Yeah.
babies to be able to break that generational trauma and this cycle. That's what we had to do. So that was long intro to how we got there, but opened our doors in 2020. We've served almost 1,000 babies, working with 137 pregnant moms right now. The need is there.
Wow. I definitely believe that. And before we came on, we had a short conversation about my experience working in child protective services here it was in the state of South Carolina, and I did foster care. So a lot of the work that I did, unfortunately, was around the trying to reunify the parents. They were already, not with their children, but trying to reunify them with their children. And I did have quite a few cases in my, 3 or 4 years there where I had children that were born addicted to any number of substance. And I can absolutely agree with you that withdrawal period is, of course, it can vary
Mhm.
for each baby,
Yep.
each substance
Yeah.
that it is, but it is a tough experience, not just for the child, but for whoever is brave enough, really,
Yep.
to take on the care of them. I do want to spend a second though to discuss, like, what does the withdrawal impact have on the baby's development? I did not necessarily work at DSS I only stayed for a few years, so I wasn't really sure what happens after that. So what does that process look like for a child, and what are some of the long-term concerns if the right support isn't in place?
Yeah. So earlier when I said that they were not our priority, literature, data is not much there. We know
Mhm.
that from what we're seeing is babies are more hypersensitive. So we have a couple babies that I was working with the moms prior to opening our doors here. And I have a few that are in kindergarten now. And it sounds like maybe there's sensory processing disorder. Maybe it's just when there's too big of a classroom that they just don't thrive there. ADHD, we're definitely there. That's in the literature, but all of the other stuff is kind of like you don't know. And it's hard to say that it was substance exposure versus like the environment that they're still being raised in. If you don't have stable housing, if you don't have
Yeah.
all of that support, all of that impacts how a child develops. And there's so many different variables. It will be interesting as we hit next year because our babies will have hit kindergarten by then to get more data to go, okay, how did you do at kindergarten roundup? What are we looking at? What do we see? It does make sense, that they're overly stimulated quicker than most people. But I think with that data, what it would be able to tell us is maybe we shouldn't put them in a 30 classroom. Maybe we should go to, Montessori or something like that, because to keep them from being put in that bucket of the problem child, because you get told that you're the problem and you're going to be the problem forever. And if we can make it that we know the environment is probably better with this group of kiddos, I mean, we're looking at 1,000 kids in less than 4 years. That's a lot of babies that are going to be in classrooms. And so we need more data.
Absolutely. I completely agree with that. And so a few different ways I want to go. So I'm like, wait, where do I start? So with traditional neonatal care, it does, like you mentioned, it often focus just solely on the baby. Can you tell us more about how Hushabye takes a more holistic, family-centered approach?
Yeah, yeah. So our hope is that a mom finds out she's pregnant and her aha moment of, I haven't been able to get well. I'm gonna have to, I've got to. Hopefully we meet them prenatally. Our very first words were whenever we meet them, if it's the day before rights are gonna be severed, it's that day. But the first time that we meet them, it's congratulations. Babies are supposed to be celebrated. Being a parent is such an honor. Telling them congratulations is huge. And what you're able to do with just that one word is break down barriers, and then you start building trust. And so really being trauma informed and understanding that, I always tell my team, I'm like, we are not here to judge. This could be any of us. I heard somebody like say it recently, we're all 4 bad decisions away from being in prison. And I'm like, oh my God. Yeah, that really could happen. So you hear about that. Not judging them is probably the biggest thing. When we meet them for the first time, we focus on their baby. Because believe me, they have tried to get well in the past, and they haven't been able to. They feel worthless. They have no hope. They're like, but I need to do something for my baby. And so initially when we meet them, it's, do you have a car seat? Oh, you don't? Well, let's do a car seat class. Let's teach you how to put a baby in a car seat. We partner with the Department of Child Safety to give them a free car seat after they do the car seat. We teach them how to swaddle their baby, how to shush them, how to calm their baby going through these things. Then as you start doing that, they start doing our groups, learning about safe sleep, all the different things. Then they realize that, so Department of Child Safety is going to be involved, which they are. They're going to be involved in every one of our families. But we start to change that narrative of Department of Child Safety being the bad guy to, how about we, instead of making them it being a punitive relationship, let's make it a collaborative relationship. When they understand that DCS, Department of Child Safety, wants to make sure your baby's safe, and their second goal really is family unification.
It is.
When families hear that and they meet people from Department of Child Safety, we have groups where they jump on, they can ask questions, they can do all of the things. When they hear that that is the overall arching goal, then they're like, okay, so what can DCS do for me? Oh, you can help me with housing. Okay, now I'm like very interested. And what you find is this partnership. Yes, Hushabye is in that partnership with them, but you find that, God, we're all just surrounding this baby and this family with love and kindness, and like use your brains for think out of the box of how do we, number one, get family, mom and dad well. Number two, we want a healthy baby. Number three, we want to make sure that baby's safe. But how in the world does our whole community surround this family to ensure that family unification happens? We know, with looking at adverse childhood experiences, that if that baby is placed in foster care, we have set that baby up for 15, 16 years down the road, 50, 60 years down the road for chronic illness, substance use, mental health, all of the things. So we do that. Then we have prenatal, if we meet them there, where they're doing all the groups, then they go deliver at the hospital. The baby ends up at 24, 48 hours, mom and baby transfer to Hushabye. We have one-to-one caregivers, which in the neonatal intensive care unit usually have 1 nurse to 3 babies. And you have a baby that needs to be held 24/7. You have to take care of 2 other babies. That baby's just going to have to cry. It's going to have to cry it out, which babies that are withdrawing, that are born dependent on an opiate, are not going to stop crying. They're just going to keep crying. And at Hushabye, we have one-to-one caregivers, meaning I have 5 babies in the nursery. I have 5 caregivers, someone to hold that baby 24/7 on top of mom and dad. It's a quiet, dark environment with a room that mom and dad can stay in. There's a bed in the room. There's a snoo, which is a fancy bassinet. We have a changing table in every room and a rocking chair, but all in that room, that's mom and dad's baby's safe space. On site, while they're there, the parents are the visitors when they're in the nursery part of Hushabye. When they're through the doors on the other side, they're in our outpatient standard behavioral health approach. So our peer supports, we have 4 peer supports that have been through our program that now work for us. They're raising their kids, they're thriving. At any given time, if we have a mom and dad that aren't well, say they used 5 minutes before delivery, they met their baby and they're like, gosh, I got to do it now. If I'm going to do it, I can grab them, the peer supports, and go in there and go show them your baby, show them what you've done, tell them your story. And say mom isn't, maybe they're not up for it today, but maybe they're up for it at 2:00 in the morning. If they're up for it at 2:00 in the morning, my team is able to jump. We're not doing detox, but we have worked with our community partners to ensure that we're able to call, break the barriers, get them transportation, get them there. It's probably the biggest thing. In Hushabye, quiet, dark environment, one-to-one caregivers, everyone that works for Hushabye, for some reason, this is their love of their population. Don't know how. I loved caring for those babies that were a pound. Loved it. Now you give me that, and I'd be like, no, I don't want to do that. That does not sound fun. I don't know why it changes, but everyone that works at Hushabye wants to work with this population. If they know someone, if their family member struggles, if it's just for some reason these babies, they connect, everyone's trauma informed. So when families come in and we say congratulations, we honestly are thrilled that they showed up. We are excited they showed up. Not the fact of, say they used in the parking lot and they came in. Any other place would say you can't be here.
Right.
What we do is I want them there because I don't want them to overdose. I have Narcan in every room. Our volunteers, everyone knows how to give Narcan. I welcome them in, tell them congratulations. And of course, I'm not going to let them hold their baby at that time, but I'm not going to tell them that they can't hold their baby. I'm going to go, oh my gosh, you're exhausted. You just had a baby. You guys haven't slept, have you? Let's get you in the shower. Let's get you food. Do you want to take a nap? Someone that's struggling with fentanyl use, opiates of any sort, they're tired.
Yes.
Them to go night. When they go night, they wake up. As soon as they wake up, my inpatient team, Brad's my outpatient therapist or peer support, brings them in, and then we hope that there's that aha moment.
Yeah.
And when there is, we get them well. Our families, if they're working with us prenatally, so we meet them prenatally, and they're engaged at all, 83% of those families are taking their babies home safely. 83%. And I'm sure your experience was much less. We don't have
Way
data
less.
here in Arizona, but when I ask my peers, they're like less than 25% take their babies home. We have, I think, 37% last month that didn't even have DCS involvement. So we called DCS. They heard the story. They're like, okay, they're doing great. Fabulous. There's nothing else that we need to do. So we've really been able to change that trajectory in getting families well, getting the resources they need for those families that are still struggling. No, they're not gonna take their babies home by themselves. Could we get them maybe into a residential treatment center that accepts babies like a month or 2 after them getting well? We might be able to find something like that, but we're having those conversations with grandma and grandma, aunt and uncle, who's up for surrounding this mom and dad who are motivated, who are connected with a treatment center that isn't the normal treatment center, that we have data to show that maybe this is their difference. Maybe they will get well. I understand with families doing tough love. I can't even imagine, someone when you're under the influence, when you're dangerous or violent. I understand with families having to do that. We're there to do those hard things for them. So if we need to go, we have those hard conversations of, they allowed you to be in the house, but you came under the influence and then you were, verbally abusive, and now that's not going to happen. And we're able to have those hard conversations with somehow families go, okay, and they respect it because we're very transparent. I'm beyond transparent when families go, Department of Child Safety said I was going to take my baby home. And I'm like, okay, well, that DCS worker must be a brand new DCS worker because you are not taking your baby home by yourself. Your home is on the streets. So that's not going to happen. So
Right.
let's figure out what is going to happen. And, sometimes families hear what they want to hear, or not even,
Yep.
I wouldn't even say what they want to hear what they can hear.
Yes.
They're stressed. They're just had a baby. They're probably withdrawing, those things. But we're just being the good and the bad guy at the same time, holding Department of Child Safety accountable, but also the
Yeah.
families accountable to make sure that we're doing a good job. And all of us are really focusing on what's the best interest of this baby, and not just in this neonatal period or the first few days of life. It's what's in the best interest for this child as they grow up. And that, if you look at the data, is with their moms and dads, but we have to ensure it's safe.
We'll be right back after a word from our sponsor.
Americans are increasingly concerned about mental health, with nearly 9 in 10 voters seeing it as a crisis. Mental Health First Aid provides crucial training to identify, understand, and respond to mental health and substance use challenges. Gain the skills and confidence to offer life-saving assistance. We offer courses for individuals, groups, and organizations of all sizes, including specialized training for veterans, law enforcement, EMS, and educators. Visit mentalhealthfirstaid.org or email hello@mentalhealthfirstaid.org to schedule your training and make a difference in your community.
Absolutely. Absolutely. One of the first things that you said that just really spoke to me, again, I was a foster care worker, and no matter how nice, no matter how comforting I would be when I would meet the families at the hospital to explain the situation, I was still the DSS worker and I was still taking their baby away. And so you guys being able to be that bridge between the program that's really just trying to help you, because I really was just trying to reunify your family together. These are the things that are going to help you get your baby, but they really just saw you were the lady that's taking my baby away, like not necessarily seeing it for the help that we really did and do still try to provide for families to keep them safely together. So just that bridge of being the safe place for families is very impressive, and it really does speak to the trauma informed care approach that you guys take. Because I mean, most of the time these families have had some form of interaction with DSS or with law enforcement that is not a positive one. And
Yeah.
so to be able to be that positive bridge between all of those systems is amazing. Thank you.
Yeah. Yeah. I have a recent dad that, gosh, he would not call Department of Child Safety and he wouldn't work with them. And I'm like, dude, if you don't call, your baby's not going to grandma. I know you think baby's going to grandma, but baby is not going to grandma. And after talking with him, he's like, I was in the system. It was bad. And so he's looking at, trauma when he was 3 to 7 years old or something like that. And
Yeah.
my heart just broke for him. It wasn't like he's trying to be defiant.
No.
He was just like, I am so scared. And, we had to sit with him and go, let's do the call together. But we did prep the DCS worker with, this is his history. So give him a lot of grace, not just a little bit, but a lot of grace of understanding that he was in the system and this is why you're getting this guy that won't return your phone calls.
Yeah. Yeah. It's not just as simple as they just don't want to do it. It's generally not, in my experience anyway, it was generally not that parents, they just don't want to. There's a reason why that is happening.
Yeah.
Absolutely.
Yeah.
Absolutely.
It was kind of eye-opening, even after taking care of all these families for over the years. It really was, when I heard that, it kind of took me like,
Yeah.
hadn't thought of that,
Because there is usually something, and it's often that they've been in care themselves or their parents usually, there's generally something that is holding them back. There are some adverse childhood experiences there that are showing up in a number of, mental health, all kind of different ways. Absolutely.
Yeah, absolutely.
So I know all of this is a complete difference in how children and families are treated. but I do want to specifically talk about how babies are treated or taken care of in the hospitals. So my understanding is that babies that are in the NICU that are overdosing tend to be treated with levels of morphine, which was really kind of shocking to me. So what is the difference in what Hushabye does, and why are they giving babies morphine in the first place?
Yeah. Yeah. So the worst thing that a baby can do with withdrawal is have a seizure. So we can't, we can't let them not sleep or cry and get themselves to have a seizure. We absolutely can't do that. It used to be, the old way used to be, baby starts to withdraw. They say they're exposed to heroin. Yeah, they're going to withdraw. They start doing all the shakes and they won't sleep and can't tolerate food, all of the things. In the hospital, when they would come, we would just start them. You start morphine and you do it every 3 hours. And that's just what you do, because your bright lights, we didn't know how to care for them. That's what we did. And then you would, in 48 hours, you titch it a little bit, or you titch it up and titch it out. But every 48 hours, you make a change. Slowly but surely, we changed the way we assess a baby's severity of withdrawal from looking at 21 questions called the modified Finnegan, 20, maybe 22 questions that are very subjective. You could do the assessment, I could do the assessment, you get a 16 and I get a 2. The higher the number, the worse it is. So it's very subjective, not the best tool. Well, probably 5-6 years ago, Dr. Grossman out of California started a new method called Eat, Sleep, and Console. Can a baby eat? Can they sleep? And can they be consoled? They can do those 3 things. We don't need to give them morphine. And what we have done is we do Eat, Sleep, and Console with a quiet, dark environment with 1-to-1 caregivers, meaning if a baby needs to never touch the bassinet because they can't tolerate it and they just need to be held 24/7, they get held 24/7, no matter what. That quiet, dark environment with the energy that we bring in, being calm, a baby and family just de-escalate when they walk in the doors. When families first come into Hushabye, they've been at hospital, they've been judged, they've talked with Department of Child Safety, they are on edge. And within an hour of them coming in and us just saying, let us hold your baby, let's get you in the shower, let's get you some food, it all gets better. It all, that heightened goes low baseline. Babies feed off of us and feed off of their parents. And it is amazing when you look at, in the hospital, we used to 95% of the babies we put on, at least, it's probably 100% of the babies that came in withdrawing, we started on morphine. At Hushabye, if they come to us without being started on morphine, less than 8% even get 1 dose of morphine. Less than 8%. That leads to decreased length of stay in the hospital. National average now is 22 days. I think that's a very low estimate, but we'll go with it. We're less than 9 days. We're quarter of the cost, if not a tenth of the cost, depends on what you go for and where you get the resource of the neonatal intensive care unit. And then you look at us being able to keep families unified. We're saving money in the neonatal period, but we are saving money from keeping babies out of foster care, keeping families together, helping them not utilize the emergency room, all of the things that I haven't been able to do yet to put a dollar amount on what we do just by being engaged with one family for that child's life. The cost savings are enormous. I knew that we would make a difference. I had no idea that our data would be where it's at. And it's been from 9 babies to over 900 babies. It's right about the same, 7 to 8.5 days. Us not giving morphine, it's always been less than 10%. Now morphine, some data is showing that even a single dose of morphine puts babies at a higher risk for developmental delays and deficits. Stay tuned for that. But that study's out there, and I honestly am surprised that our hospitals, my peers, are not going by that data because we go evidence-based for most everything.
Yep.
And I just feel like there's still stigma even to the baby. If you're going to start a baby on morphine, why would you not send them to Hushabye and give them a chance to see if we can not give them a dose of morphine? I'm not saying we're not going to give every baby a dose. We may give them a dose, but we're going to do it. They have a better chance of not needing it here in the right environment and with the right personnel in a trauma-informed environment to make them succeed.
Absolutely. And so when babies, let's say you mentioned they are in the NICU for 8 to 10 days, what happens after that period? Are families still allowed to remain there and stay in their own little room? Like what happens later? And then what are the behavioral types of supports and programs that you offer for the parents to eventually become self-sustaining?
Yeah, we're working with them. We have case managers that are working with them, very, very closely, working with a different treatment, residential treatment that will take mom and baby. There's one that will take dad and baby, but it's hard to get that to work out. But we're working with them going, okay, what's going to work with this family? And then we're following up. They get discharged, follow up at 48 hours a week, 2 weeks, a month, and then along the immunization schedule. And when we're calling, we're going, how are you sleeping? How's baby sleeping? We do a postpartum depression scale. We're helping them, say somebody needs help with rent. We're going, okay, have you filled out the rental assistance application? And if they haven't, then we're doing it with them. We're not just sending them the 20-page application and them doing it. It's like, let's do it together. Let's get it done in there, because when you have a brand new baby, you don't have time to fill out all of that stuff.
No.
And so we will just work with them. When baby's ready to be discharged, parents are not able to stay with their baby at Hushabye. But we're figuring out where the plan is as far as disposition. Our number one is hopefully, if we get them well, being able to prove that they're well, make sure they have housing, food, transportation, all of the things. That's our number one hope. But say we don't have housing, if I can get a mom into treatment before she has that baby, I usually can get Department of Child Safety. If she's in the right treatment center, I usually can get them to go, yes, this is safe to send baby to treatment with mom, but she has to be in treatment before she delivers. So I have to, get her stable on medication-assisted treatment, methadone or Suboxone. I've got to get her stable before that delivery. If mom is unwell up to delivery or after delivery, we have to figure out what's another option to ensure baby's safe, but keep families together. And that's when we're going, is there a friend? Is there a grandma and grandpa? Or is there an aunt and uncle? Let's think out of the box. I had one mom that nobody could take mom and baby for 24 hours, but her parents were divorced and then they were divorced again. So she had 4 sets of family that were willing to surround her and keep her and her baby together. And literally they would go like Monday, Tuesday, they'd go to this dad and then this mom. And then Wednesday, Thursday, they would go, to all 4. What we were able to do was document that for DCS to go, here's the schedule. This is what's going to happen. I know that this seems hard, but they are willing to do it. And this is what they're all saying they're willing to do. And that mom within 2 months got her screen lifted. And she came to one group and I can remember going, where's baby? And she goes, Tara, I can't have baby. I need to come to treatment or come to the group, but I can't have baby, remember? And I was like, oh yeah, good job. I'm so proud of you. Yeah, good. You're following the rules. Yeah, don't do that. And then, then it got lifted and she was able to bring baby with her. But when you're very clear on what we're asking and you're doing it in the right tone, I guess, with the right love and, not everybody here at Hushabye has that knack. They're learning little by little to I guess maybe speak with grace and really be trauma informed. But it is hard to be comfortable around someone that is so low in their lives. You know, they're not clean. They're under the influence. They don't have, their dental is not good. I mean, all
Yeah.
of the things, it's really hard to look past that. And little by little, lots of training of our staff. A lot of our training comes from our staff talking with families and learning what families have been through. And then they share. And I'm like, see, you just needed to talk to that mom to realize that she was great until she wasn't, you know, had it like I've had so many knee injuries that they went home with Percocets, 30-day supply, and then they couldn't stop.
Wow.
And before you know it, you're embarrassed. You're not going to tell anybody that you're going through withdrawals, and then you're on the street. And
Wow.
yeah.
Wow. And so you mentioned earlier that you've cared for nearly 1,000 babies in under 5 years, and you've just given us little snippets of success stories. Can you share with us a more hallmark story or a big success story where you took a family from the beginning of this until the end that really illustrates the impact of Hushabye's approach?
Yeah. I'm going to give you one that was probably the most recent. Mom will let me share it. So she had been a referral, but we could not get a hold of her. Like, we got a hold of her once or twice prior to delivery, and she goes into labor and she calls and she's like, I'm in labor. And to this point before, usually they're just so scared to reach out and struggling with substance use. She was right before delivery. We ended up visiting her in the hospital. She's like, yes, I want to come to Hushabye. Her and baby show up. She has not used again since that day. We ended up getting her prescribed medication-assisted treatment, worked with the provider to go, it's only lasting for 6 hours. Can you bump it up? She is so determined. She's here, but she is miserable. Can we help get her to where she needs to be? Baby and mom did great. Mom heard of other moms at Hushabye being able to breastfeed. And she's like, I want to breastfeed. And we're like, you have to have a normal drug screen to be able to breastfeed. And she's like, okay, it should be normal. And we tested like 3 days after, it was still abnormal. Tested 4 days, it's still abnormal. I think we on day 7 finally had a normal drug screen, and she had been pumping and dumping, but had not used. I mean, she's like, I haven't used, but obviously it's been in my system for this long. And on day of discharge, we thought that grandma was going to take mom and baby. And grandma at the last minute said no. And we were like, okay, now what do we do? And mom called me, and it was here in the winter. She's like, do you have a blanket that I can use? And I'm like, what are you talking about? A blanket? Well, we had a treatment facility as a backup for mom and baby, but then that fell through because baby went to foster care. And so we had grandma as an idea that fell through. Then we had a treatment facility that fell through. We didn't have any place to put mom. She was homeless. And so in the middle of the night, well, it was like 10 o'clock at night, she calls and needs a blanket. And I'm like, okay, she can't stay with us because we're not licensed that way. I'm like, but she can't be on the street. Oh my gosh. And so I'm calling everyone that I possibly can. And we have another nonprofit that kind of sober living, but they do some behavioral health services on site. And that owner went to one house, got a bed, brought it to the other house. 11 o'clock at night, we're getting this mom into that sober living place. So when she did this, she asked, how soon did I think her and baby would be reidentified? And I said, 6 months. 6 months is going to be the earliest. She had rights severed with 2 other babies, another one out of home. I mean, there was a history. And I'm like, 6 months. Nothing ever did she hurt her kids, but just substance use. She got baby back within 2 months, breastfeeding, has a job, going to treatment, and still not using. And she jumps on groups. I see that she jumps on them, like, look at that chick. And she is amazing. Before she got baby back, we have another program here in the Valley called Dress for Success. So something like that. But it's another nonprofit that you take them to. She had a job interview. They got her a suit. I mean, it's secondhand clothes, but dressed her all up. So she was ready. She sends me a picture and I'm just like crying. The whole staff is crying, going, oh my gosh, look at this. And, you know, she would send pictures of every time she's getting visitation with her baby and first saying, you know, no, I'm going to do this. And us just going, you're right, you are going to do this. And she is. And so you just go, yep, that's why we do it. So,
Absolutely. That's amazing. Thank you for sharing that story. That's awesome.
yeah.
That's awesome. You guys are doing great work.
Thank you. Thank you.
And so in my opinion, I feel like programs like this one should be, it's not every city, at least in every major city, but I know that the expansion has got to be challenging. What barriers exist when you're trying to partner with hospitals, insurance providers, and how are you guys able to overcome them?
Yeah, that's still hard. It's hard when you look with it, just speaking towards hospitals, for them to understand that we're not competitors, but we're just a partner. That's hard because when we take a baby out of the neonatal intensive care unit, if they're not full, we just took revenue from them.
Yeah.
$60,000 to $80,000 I took from them. That's a biggie. Working through that, you know, just trying to do as much education, helping everyone understand the adverse child experiences, sharing the new data on morphine use. Very interesting. The pushback that I got on it, I'm like, this is a good study. And I am so surprised you're not taking it, but they're not. That's with the hospitals, with the payers. There's no license type in the nation for what we do. And so we are licensed as an adult detox. That's the baby care that we do. Okay. And then we're standard outpatient behavioral health, which that's a licensed type. But the baby land, there isn't. And so when you say reimbursement from 97% of our babies are covered by Medicaid, the reimbursement for an adult detox is less than 50% of what I need to be sustainable. So you get like $600 a night reimbursed, because an adult detox, you don't have nurses on 24/7. You don't have a provider seeing an adult every day. We're doing that. I have a provider seeing a baby. We're changing the treatment plan every single day, if not a couple times a day. We're doing all of those things. So that reimbursement isn't great. Our Medicaid here in Arizona is trying to figure out how do we maybe make a different licensure type or a different payment model. That's going to take a long time. Did I think it would take this long? It's taken a long time. They definitely support us. I mean, we save them a lot of money. So there's that. With the new administration, the federal funding cuts, that's hit us really, really hard. And I mean, we are just going, okay, what other avenues do we have? Because our reimbursement isn't enough for what we do. If my beds are not full because hospitals look at me as a competitor, then I'm losing revenue. And so that is just, it's a toughie right now. I'm hoping that all of the chaos can finally settle just a little bit and give us a little, can we stop changing everything and let us keep moving? Yeah.
Right. Okay. So for practitioners who might be listening, who want to support neonatal wellness and family-centered recovery, what are some ways that they can do to help, or how can they get more information?
Yeah, I think the biggest thing I'd recommend to them is watch the 15-minute YouTube TED Talk by Nadine Burke-Harris.
Oh, that's awesome. That's my favorite.
That is what they need
She's
to
amazing.
watch. Yeah. Because as soon as they watch it, they're going to go, no, I understand why Hushabye. Had no idea, but that explains it. That was my aha of going, well, crap, this is real. And then you read more and more and more, and you're like, oh my gosh, this is really very important. So that, number one. Number two, they can always just reach out to us on the web. Hushabyenursery.org is how they can reach. Otherwise, 480-628-7500. They can call or text that number, and we can get back to them about, kind of what we did. The issue is every state is different. every Medicaid is different. You know, we have other people that are trying to do stuff similar in Ohio and Seattle, and everybody's different. Some are under Department of Child Safety licensure. Some are under, just not even mental health, nothing. And it's like, okay. And we all are trying to save the families in a
Yeah.
different way. I'm a nurse from background, so I look at it more as medical. Others, like starting out, there's a foster mom that started a place. There was actually a couple of foster moms that did it. And so looking at that different setup compared to my setup, because I'm very much medical,
Gotcha.
and making sure that we get the babies and all my data and all of that, where theirs are just a little bit unique.
Yeah. Nice. Okay. Well, Tara, thank you so much. I have really appreciated speaking with you today.
Yeah, thank you so much. It's been great.
Absolutely. And thank you to our listeners for taking the time to join us. Make sure to follow us on our social media at Instagram, TikTok, LinkedIn, and more. We're also on YouTube at Behavioral Health Today. And if you like our show, be sure to give us 5 stars and leave us a review. That helps our show get discovered and share the valuable insights in each episode. As always, the resources for this episode and an archive of all of our other episodes can be found on our webpage at triadhq.com/BHT. And we look forward to having you back with us next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.